Tamumbi. Good afternoon, everyone. I'm going to introduce the speakers for today, the moderators. We have two moderators, both of them very highly accomplished consultant vitreoretinal surgeons. Dr. Asiwome Seneja is a consultant VR surgeon currently stationed at Dr. Agawa Eye Hospital in Ghana. He completed his undergraduate studies at the University of Leipzig in Germany, and thereafter he obtained his M.Med. Ophthalmology from the University of Nairobi in Kenya. In 2009, he obtained his vitreoretinal certificate from KCMC. He served as HOD and consultant ophthalmologist as well as VR surgeon at Kitwe Central Hospital then between the years 2000 and 2014. Currently, he's the medical director at Dr. Agawa Eye Hospital in Ghana. He has held several positions, both locally and internationally. At the time that he was the HOD at Kitwe Central Hospital, he was also the medical advisor lecturer at UNZA. He also held the position of General Secretary for ZOS and is also a founding member and current chairman of the Africa Retina Society. Dr. Seneja is a member of several professional societies, which include the Zambia Medical Association, the Ghana Medical Society, American Academy of Ophthalmology, COEXA, ZOS, and the Ophthalmology Society of Ghana. He is also a fellow of the College of Ophthalmology for Eastern, Central, and Southern Africa, and at the Ghana College of Surgeons. Our second moderator is Dr. David Kasongole, who is also a consultant ophthalmologist and VRS surgeon at Dr. Agawa's Eye Hospital in Lusaka. He attained his medical degree with honors in Russia and a master's degree in ophthalmology from the University of Nairobi in Kenya. Between the years 2017 to 2018, he completed his long-term fellowship in retina and vitreous at LV Prasad Eye Institute in India, following which he practiced at UTH until recently when he joined Dr. Agawa's Eye Hospital in Lusaka. He also won a short-term uveitis fellowship grant under the International Uveitis Study Group in 2011. Dr. Kasongole has also been on the Leadership Development Program hosted by the African Ophthalmological Council and is scheduled to graduate this year. He is the current coordinator for ICO examinations in Zambia, which he also facilitated to set up in 2013. Dr. Kasongole, as we all know, is the current president of ZOS. He's also a member and an examiner for COEXA. Dr. Kasongole's interests in postgraduate training, mentorship, and research, and he has published in both local and international journals. And our presenter is Dr. Juliet Mulenga, a third-year registrar at UTH Eye Hospital. With those few words, I'd like to hand over back to the moderators. Thank you.
Thank you, Dr. Moka. Dr. Mulenga, you can take over the show.
So I hope everyone is able to see the screen. Okay, I'm going to start now. Good afternoon, everyone. Today's presentation is going to be on age-related macular degeneration. As mentioned, I'm Dr. Juliet Mulenga from UTH Eye Hospital, and my moderators are Dr. Kasongole and Dr. Seneza. So the outline for this presentation will include an introduction to the topic, then we'll move on to the journal article, and then we'll critique this article using the Marie method. So age-related macular degeneration is a progressive degenerative disease of the retina, which is the leading cause of blindness among older people in Western countries. Risk factors include age, race, smoking, hypertension, dietary factors, aspirin, and other factors such as cataract surgery, blue iris color, and high exposure to sun, and also the female gender. How it comes about is there is chronic, the effect of antioxidants and visual psychoinhibitors on the retina leads to chronic oxidative stress, which then affects the photoreceptor RPE and Brooks choriocapillaries complex, which leads to chronic inflammation and accumulation of extracellular and intracellular debris, which then leads to the drusen formation and damage to the photoreceptors and the RPE, which can either result into geographic atrophy or neovascularization. So clinically, AMD can be categorized into 5 categories. The first one being no apparent aging changes, which is where there is no drusen and no pigmentary abnormalities. The second category will be normal aging changes, where there is only droplets but no pigmentary abnormalities. The third category would be early AMD, where the medium drusen that is larger than 63 micrometers but smaller than 125 micrometers with no pigmentary abnormalities, and intermediate, where there's a large drusen, more than 125 micrometers, and any pigmentary abnormalities. Then there's also late AMD, where there is neurovascular AMD and or any geographic atrophy. So when we talk about the 2 major types of AMD, there is dry, also known as non-exudative AMD, which is the most common type and is responsible for about 90% of the cases. It's characterized by drusen and pigmentary changes and atrophy of the RPE in the macular region, which is also named as geographic atrophy, as seen in this fundus photo of the right eye. On OCT in dry AMD, you can see medium-sized and large drusen, which are seen as hyperreflective irregular nodules beneath the RPE and are located on or within the Brooke membrane. While wet AMD, also known as exudative, is less common and it takes about 10% of the cases that we see. It's characterized by choroidal neurovascularization, intra or subretinal fluid, and lipid exudation. It also results in severe vision loss. On OCT, we can see irregularly shaped fibrovascular pigment epithelial detachment and adjacent subretinal fluid and subretinal hemorrhage. Also, choroidal neovascularization can be seen on OCT. So wet AMD can be divided into 3 types based on its appearance on FFA. These are classic, occult, and mixed types. When we talk about occult, it's characterized by ill-defined area of staining and leakage and stippled with hyperfluorescence, as seen in the FFA image. And when we talk about classic, it's characterized by a lacy pattern of hyperfluorescence in the early phase, followed by increased intensity in the mid phase, and then leaks in the late phase, obscuring the boundaries. Other investigations could be use of the Amsler grid, Snellen chart, and ETDRS, which stands for Early Treatment Diabetic Retinopathy Study, which is another method of estimating visual acuity. So there is no effective treatment for dry AMD, but the use of dietary supplements and antioxidants, cessation of smoking, and advising the patients on how to use the AMSA grid regularly, and the use of low vision aids have been found to be helpful. The main form of management for wet AMD is the use of intravitreal anti-VEGF therapies, for example, bevacizumab, ranibizumab, pegnatamib, and aflibercept. So in our journal article, we're mostly concentrating on bevacizumab, ranibizumab, and aflibercept. So just to go into details about bevacizumab, which other name is known as Avastin, it's a recombinant humanized monoclonal antibody that blocks angiogenesis by inhibiting vascular endothelial growth factor A, and the dose of Avastin is usually 1.25 milligrams, that is 0.05 mils. Or ranibizumab, which trade name is Lucentis, is a recombinant humanized monoclonal antibody fragment that non-selectively binds to all isoforms of VEGF-A. The usual dose is 0.5 milligrams in 0.05 mils. Aflibercept is a recombinant fusion protein that binds to VEGF-A, VEGF-B, and placental growth factors. Unlike Avastin and Lucentis, which only bind to VEGF-A, aflibercept binds to VEGF-A, B, and placental growth factors. The standard dose is 2 milligrams in 0.05 ml. So we need to take note that the time this journal was published was in 2017, and since then there have been introduction of newer anti-VEGF therapies, such as brossolizumab, which trade name is Novartis, abicipar which trade name is Allergan, and faricimab, which trade name is Genentech. Other treatment for wet AMD include photodynamic therapy, PDB, which is the use of photosensitive dye that activates only in abnormal blood vessels, and the use of a cold laser, which selectively distracts all the abnormal blood vessels. The other treatment is laser photocoagulation. So now we move on to our journal article, which is titled Switching to Aflibercept Among Patients with Treatment-Resistant Neovascular Age-Related Macular Degeneration, a systemic review with meta-analysis. It was published in the Clinical Ophthalmology Journal on the 6th of January 2017 with an impact factor of 2.04. It was a multi-setting study. The places it was set were in Sydney Retina Clinic and Day Surgery, in Sydney Institution of Vision Science, and in SaveSight Institute, Department of Ophthalmology, University of Sydney in Australia. The objective of this study was to systematically review anatomical and functional outcomes subsequent to switching from Avastin and Lucentis to aflibercept monotherapy in patients with treatment-resistant neovascular age-related macular degeneration. The study design was a systematic review and meta-analysis. The research study, the Medline, PubMed, MBIS, and Cochrane databases were searched for available scientific literature which met the inclusion criteria. And these databases were searched between January 2012 and January 2016. The inclusion criteria was as follows. Patients who were aged 50 years or older with active subfoveal CNV lesions secondary to AMD who are resistant to previous anti-VEGF therapy. Also, early treatment diabetic retinopathy study best corrected visual acuity should be between 75 and 25 letters, which translates to 9.5 to 695 on the Snellen chart. So the studies were selected by screening citations by title and abstract. They identified all studies for full review to confirm eligibility. They selected independent studies for their inclusion in the systematic review, and any disagreement between these reviewers was resolved by a third reviewer. Then a decision to include and exclude a study was reached by consensus. Statistically, they screened articles and extracted data following the preferred reporting items for systemic reviews and meta-analysis, also known as PRISMA checklist. They tabulated data such as mean change of VA, central retinal thickness, and pigment epithelial detachment height from baseline. The Cochrane Handbook was used to obtain standard deviation from range, median, or p-value when present, and the best corrected visual acuity data was converted to ETDRS letter score. The data was summarized both qualitatively and quantitatively, and they independently assessed potential sources of bias according to the Downs and Black checklist. So the data was synthesized and analyzed using the comprehensive meta-analysis version 2.0. All results were subjected to double data entry, and effect sizes were expressed as mean differences for continuous data with 95% confidence intervals. Publication bias was assessed with funnel plots and Eggers linear regression. So the results are shown in this table. 82 records were identified through database searching, and from those 82 that were screened, 39 were excluded. Then full text articles which were assessed were 43. From those 43, 15 full text articles were excluded due to one that shared the same sample and time, 3 assessed PCV lesions, 6 under time length, and 5 had insufficient data. So there were 28 studies included in the qualitative synthesis and 28 studies included in the quantitative synthesis. So the mean age which they found from the studies was 70.1 to 83.4. 59% were female, and the mean best corrected visual acuity was 42.50 to 74.20 ETDRS. The mean central retinal thickness was 228.60 to 449 micrometers, and the mean pigment epithelial detachment height was 122.8 to 313 micrometers. So in our first forest plot, 19 studies were reported on the best visual acuity after 6 months switch to Aflibercept. So some studies showed a decrease in visual acuity, while some studies showed an increase, but most of them showed no change in visual acuity. So the summary measure of all the studies was just above 0 and less than 0.50, which was not much of an improvement in best corrected visual acuity. In the second forest plot, it showed 15 studies that reported best corrected visual acuity after 12 months after switching to Aflibercept. The summary measure of these studies falls at 0 and less than 0.5, which also means there was not much improvement in best corrected visual acuity. In the third forest plot, it reported on 17 studies the results of central retinal thickness after 6 months switch to Aflibercept. The mean change of the studies showed a decrease in central retinal thickness. In table 4, it showed 11 studies, results of central retinal thickness after 12 months of switch to Aflibercept therapy. And the mean change of the study showed a decrease in central retinal thickness more than that of after 6 months. The last forest plot showed 8 studies reporting results of pigment epithelial detachment height from baseline after 6 months of switch of therapies to Aflibercept, and the mean change of the study showed decrease in pigment epithelial detachment. So the authors noted that there was evidence of possible publication bias when assessed by funnel plots and by Eggers test, indicating that the treatment effect was overestimated as majority of the studies were having small population sample. The author's interpretation was that patients with neurovascular AMD who have inadequate response to Avastin and Lucentin may benefit by switching to Aflibercept therapy. Though they noted that vision did not significantly improve, but vision stability was achieved, which may have an immense impact on the patient's quality of life. Then changing to Aflibercept with a loading dose and PRN region on individualized basis may prove to be an effective management strategy. Some of the limitations that the authors noted were that majority of the studies had small population, meaning that the treatment was overestimated. Majority of the studies were retrospective in nature, and there were no randomized trials to accommodate for confounding variables, and there was considerably variability among study designs and dosing regimes. So we'll now move on to the last part of our presentation, which is the Marie. On methods, the study question was defined, the inclusion criteria was defined, the exclusion criteria was not clearly defined. The assignment, it was a systematic review and meta-analysis. On assessment, the study question was answered, although the sample size was small and the treatment effectiveness was overestimated. The inclusion criteria was very clear, but the exclusion criteria wasn't very clear. And also there wasn't a standard dose for Aflibercept across all the studies, which could affect the results. In terms of the results, the data was well presented, and my interpretation of this journal was that Aflibercept can be used in patients with neurovascular AMD who are resistant to bevacizumab and ranibizumab. There will be no visual improvement in these patients, but at least visual stability can be achieved. And switching to Aflibercept leads to a reduction in central retinal thickness and pigment epithelial detachment. So what I extrapolated from this study was we should consider introducing Aflibercept in our clinical practice as part of the management for neurovascular AMD. And patients with neurovascular AMD need to be closely monitored and need regular reviews so that we can assess for treatment resistance in these patients. So I'd like to propose a study question, taking that there's not a lot of information in Zambia about the prevalence of age-related macular degeneration. My study proposal would be, what is the prevalence of age-related macular degeneration? And if we could start from there, then maybe we can make more researches in terms of the therapies that we can use in Zambia. Thank you.
Thank you for the presentation, Dr. Mlenga. Well,
Thank you.
Dr. Sineja,
Yes.
would you like to start?
Okay, let me start. Thank you very much. That was very good presentation. I read the whole article, and also we had some conversations, and I think it is well presented. You did very well. That's good. Systemic review is not that easy because there can be a lot of factors that need to be considered. Just going back to the introduction, you made mention about the classification. Currently, we try to classify it a little bit different, whereby we have the ARMD type, the wet type in 3 groups. We have the type 1, which is only vascular lesions just under the RPE, and that is almost compared to the cold. Then we move to the next one, which is the classical. And that is when it has broken through the Brooks membrane and then the RPE and into the, what do you call it, into the retina. Then the third one is the wrap, where the vessel actually starts from the retina, trying to communicate with the lower vessels, which is the choroidal vessels. So that is just something that need to be updated. So it depends on which literature you read. The current one, they use that quite a lot in explaining. If you look at the study itself, it's a little bit older. I mean, if you hear what they said, I think they just started this study when Aflibercept just came out as something to deal with. So already there could be a little bit of bias there, whereby they want to really show that actually Aflibercept will solve that problem of what do you call it, resistant EMDs, which are not responding to Avastin and then Lucentis. One of the things which is for me very important when we are doing this analysis, systemic analysis, systemic review is the topmost. We know that is the best. But it's only best when there are many factors taken into consideration, like the way it is done, people, where they get a literature from, how they actually collect the information, the criteria. That is where the bias can come in. What do they want to show? They can go in and say, well, look, we don't want people who are young, yeah? And that, for instance, may be a case for us in Africa, where we have male people who are than the age group they think to have these kind of problems. We will see later down the line. And that is one of the things that you have to. Now, at the end of this, I think they have done well in terms of the literature search. The literature search was quite extensive, and they have really made somebody who should come in whenever there is a disagreement between the two reviewers, so that they can consensus. Another added thing that they did, which is very good. But at the end of it, I think the most important thing is how is that applicable in our setup? The population that they've used, the age group that they've used, how can we apply that? We are not going to start using Aflibercept because this study says we should use Aflibercept. But we have to look at it. We have to look at the cost benefit, whether it is can be used for our people. And we need to have other studies to support this kind of review. You'll be shocked that Lucentis has also, there's another study review from Lucentis trying to downplay Aflibercept as well. So it's also something that we need to take into consideration. Now, coming back whether this study will benefit our population, or group, I think it will us. But the cost is something we have to always bear in mind that can always work against our decisions. Aflibercept currently is not that cheap. Even the Lucentis is not that cheap. And then now Aflibercept. When it first came out, they say it's actually bi-monthly. That means when you give the injection, people can be away, for 2 months. But in practical point, we haven't seen that yet. It's just like the Lucentis. So it's one of the things that we need to take into consideration. Now, if you look at AMD, in those group of diseases that affect, we're talking of neovascularization, clinically, we tend to see more people who have polypoidal chororetinopathy. Yeah, people who have vasculopathy more than AMD. So we need to really know a way of differentiating those cases so that we don't end up, because the management can be slightly different and approach, and the age group can also differ. And the features are different. But what brings the difficulty is when they come late and they form a scar. Then it's very difficult to know what it was before it becomes. But with the advent of this technology of trying to screen patients with this new equipment, we will be much in position now to differentiate these cases early enough to know whether it is PVC or whether it is AMD. I think briefly, this is what I can think. But otherwise, the study generally was good. Heterogeneity was not bad. I think it is good when you look at the way they plot on the forest diagram. So, and then the number of cases they included was also large. I've seen some big variation in some of the sample sizes. Some were very small, although some were big. And it's very difficult to make that kind of comparison when it comes to the samples from this study and the sample their study. But otherwise, in all, this is what I can say so far, unless there's something come in mind, then I'll say it. But excellent, Dr. Mulenga, you did very well.
Thank you.
Very, very good views, Dr. Sineja. Quite enlightening. It was a very good study. I thought as much. Maybe just to add on a few points. And just to make a correction, I think on one of your slides, Dr. Mulenga, you had talked about the new anti-VEGF drugs, where there was brolucizumab and the others, and then so Novartis. Those are companies that putting the drugs on the market. Say that those drugs, for example, like brolucizumab, its trade name is Biovo. That's what it's called on the market. And then I like the idea of the last slide you've put, where you wish in Zambia to try and see what the people. And the other day we're actually trying to have a discussion on another group. We're trying to encourage ourselves to collect more local data. Some years ago, we used to be told that AMD does not exist in Africa. So simply expect that there's no AMD in Zambia, and which is not the case. We have, as I've seen, Zambia to have, AMD. So a very good, topic for someone to research. We should also try and be careful to note that AMD, as much as disease of the choroid, where the new vessels start from, go under the RP and into the retina, other disease entities can cause such a picture. Dr. Sineja had mentioned that PCV, among others, trauma itself. If you have trauma can cause CNVM, which you might want to that, oh, this is AMD. So a good would one the other. Excessive of laser that we do, the laser that we may want to do, we need to be how we put set power choroidal vascularization, which we may mistake for a case of AMD. So away from there, in this study, they had enrolled patients who had AMD, and these patients were already on anti-VEGFs for some years. And now the question was to try and switch because we're not responding to the use of our famous Avastin and Lucentis. So the idea was to see if we use Aflibercept, can it induce change in these patients? And indeed, in this study, Aflibercept showed that, and as we know, and as Dr. Mlenga had mentioned, Aflibercept has a higher affinity for VEGF-A and VEGF-B, and also it also has an affinity for placental growth factor, which Avastin does not have. Avastin and Lucentis, they only act on VEGF-A. So if all worlds were equal, one would say, let us stop using Aflibercept. But like Dr. Seja has said, the cost of Aflibercept is what comes in our way. Aflibercept goes for about $1,000. So you can imagine patients with AMD have to literally have an injection every month. And if we have to check how many would afford this treatment, very, very, very few to mention. But science, it is what it is. We need to know what works best. And if people can afford, we should always feel free to prescribe and let them use the same. And also just to keep it out of back of minds that as we use anti-VEGFs, we should know that there will be a time when there will be no effect at all. And as I said, 25% of patients are non-responders. So after some time, you have a patient you've been injecting, then for no reason you see that the drug is no longer working. It's time to switch. And from the outset, when you want to initiate the treatment, you need to explain to the patient that one, you may need multiple injections because patients usually want to think that it's only one injection that is required. But you have to inform that you may need multiple injections. And if this injection fails, there will be need to switch to another injection that is more effective. Also, something new effect. And just to comment on one thing also we had brought up in the mode of how we inject anti-VEGFs, there is a PRN means the patient comes to you, do as at the level of the macula, you give an injection. That is endorsing. This study shows patients an increased mean improvement in those 3 months. I'm going to eat every month, regardless of what the OCT shows. Then once you've seen that there is some sort of response, you take a break. You tell the patient, oh, come for review in a month's time. You do an OCT. OCT shows there is fluid, there is swelling, you give an injection. So that is dosing and PRN. I think commonly in our setup, what we practice is the PRN mode. And then the mode that is used in Europe extends. So in the treat and extend more anti-VEGF, you in 1, 2, 3, 4 months, and then thereafter, you don't have to give them another injection the following month. Okay, so what you do is you give them a breather, you give them a break, and the next injection, you say, okay, if I gave you in September, the next injection will be in November, regardless whether the OCT shows swelling or no swelling. The patient has to receive an injection. So you give it, but of course you would have done an OCT, but regardless of what it shows, you give the injection. So at that point, based on what you see, the OCT looks good. You increase the next review time for the patient, okay? Let's say from a gap of 1 month to 2 months. So they come at 2 months time, there is still no fluid, you still give an injection, whether the OCT shows swelling or not. But the next thing that you do is again extend the duration of the review. So this has been looked at even in this study. The authors or many other authors have assumed that these patients, they are very old. and getting them to the clinic every month is a huge challenge. So if you can give them an injection and give them this sort of breather, that of course, if it's showing that things are working, it helps them to go on. And as opposed to where you mandate a 70-year-old patient to always come to the clinic every month, it becomes a huge challenge. So the treat and extend can in such scenario. Of course, if you've got an energetic patient whom you're sure that they can come every month, well, you can as well use the PRN mode where you see them often, you do an OCT, it shows fluid, you inject. It shows nothing, you don't inject in that manner. And then the other important point that was shown in this study, what we see from this study is that the visual acuity for these patients did not improve. ARMD, there must be drusen and all that. Most of the patients from Asia or that very had the in India is that the patients who present geographic atrophy. So geographic atrophy is something that is more classic in presentation in Asia as opposed to the West, where drusen is something that comes up first. Thank you.
Thank you, Dr. David. Am I audible?
Yes, yes, yes.
So excellent presentation by the presenter. I could not go through the journal, but then I have to the presenter. I have something to ask the presenter. That what was in the inclusion criteria? It was mentioned that treatment resistant cases. So what? How do you? How they define the treatment resistance? Like after how many injections? If there was no response, they switch to the other medicine. I would like to know from the presenter or anybody who has read that journal. I hope you got the question, no?
Dr. Mlenga, are you there?
Yes, I'm there.
Yeah.
You must have read more than us.
Yeah, that's true. Yeah, she can teach us.
So the article did exactly the patients were considered treatment resistant. So I had to read other articles to come up with understanding of what that treatment resistant was. And that other articles which I came across was saying after a period of 6 months of starting the therapy, there was no improvement of the symptoms on the OCT. And an article was talking about even though the patient has maybe 3 doses of Avastin, but there's still increase of the subretinal fluids and the neurovascularization, then they would consider that as treatment resistant or non-responders.
Okay, I got it. So I think usually we follow this one, like 3 doses of anti-VEGF, 1 month apart. And if you don't get a response and we see worsening of the condition in the OCT, we switch. I think that I follow that. And 3 options, one is Avastin, another is Lucentis, and then Aflibercept. So in our practice, I think in my practice, we decide what patient can afford. And undoubtedly, in my experience, I feel that Aflibercept is better than the other 2 because it has got, I mean, as Dr. Asi has already explained why it is so. So patients with insurance may afford it, and even with Aflibercept, you can have treatment resistance. That we have even switched to Avastin to get a better effect, and we get the effect. So it is there. The very frank. So in our practice, and I mean, expect by these 3 injections, it is going to be over. So then that's the time when you have to give the news that no, it's not over. If it is best, doctor. List separately with the phone numbers and all. If they don't come to get more insights to the usage of the Civ Aflibercept, is an off-label medicine which is again used for malignancy, but then effectively being used across the world for a. I think that's all. I think excellent presentation. I hope to see more in this forum again.
Thank you, Dr. Taramis. And a wonderful point on the study done by Dr. Jesha. He was my consultant. Yeah. So, Dr. Prasad did, because obviously not many who afford so Aflibercept, we still so for such Zif Aflibercept, and that was almost like the way one would use Avastin. We saw much or most of it. But the only drawback is I think it's only produced for the Indian market.
Oh, here we Mauritius.
Ah, great.
Yeah, you need special permission for that, but then we get that. Yeah.
Any additions, Dr. Sneja, or from anyone else? Dr. Mumbi?
Yeah, so there was a question from Dr. Fred Mubiai. I think the question has been answered already. Dr. Fred, has your question been answered?
Yes, answered. And because we had a similar discussion in our local journal here, where we just discovered that the different anti-VEGF, there's no one who is like a bit superior to the other one. But Aflibercept, it looks like it's best, but the cost effectiveness, what is there. But in the other study we read, we just discovered that even if in the switch of Avastin or to Lucentis, it was still giving some effect, but it depends with the stage where the patient has been entered into the study. If already there is a macular scar and other thing has already settling, and even the result, it won't be better even with the best medication. And the question what I had last time, it was just on the respondents, and it has been answered.
I was just wondering to the moderators in our practice among the Africans, both in Ghana and also in Zambia, how often or what's the prevalence from your experience of ARMD compared, for example, with Asia and also with the Western countries?
Let me first, I think this kind of statement can be very biased at the moment. I always mention that, you know.
Exactly.
The cases in India are very good because they have a very good screening point. Almost on average, everybody has got OCT. There's so huge cataract surgeries going on, you screen the patient. When you see a lesion, you send to the retina surgeon. In our setup, we haven't reached that stage. So we can come up with a lot of bias and say these things are not there. But retina is a subspecialty which depends on referrals, which means that if we don't have people seeing those patients, they won't come to us. Yeah, so you see that the OCT, which is very good for screening those cases, are just in the same centers. Yeah, but you look at other countries, you see that these investigation equipment or imaging equipment, they are all over. So they want to do cataract, they are not doing those wide, dense cataracts, so they are able to do OCT. And then when they do OCT, they find a lesion. Yeah, and immediately they refer to retina surgeon. So the natural history of those cases are much better. Even if you watch their case presentation, you see that they have a very nice way of telling. Most of our cases that are coming are cases that are from choroidal membrane. Yeah, they form membrane scars. So it's very difficult to say this is what we have. But generally, there are still less who present. Okay, we have more PCV, they come a bit earlier, even as young as below 40, you will see them, yeah, which will later tend to be a scar in future. Okay, so it's very important that this is understood. Now, let me bring something very clear. One, we need to really understand. We have to personalize some of these benefits, but a group of people will not be, whether it's Aflibercept or what do you call it, ranibizumab or whatever, they will all not all. So personalization of some of these drugs is key. So you discover, like Dr. Amisa said, that sometimes they have to even switch from what Aflibercept to Avastin, you see. So why is it? That's the question. That underlies inflammation. And there are many components that we just pick one of them, just which is VEGF. But there are many factors that build up to inflammation. And you know the ischemia and inflammation, you can't separate them. Once you have ischemia, the body wants to heal whatever is damaged. That is where the inflammation cells are. That's why some people even benefit from steroid injections. Yeah. So this is where you have. So don't be surprised one day somebody comes and with another drug that targets completely something, which we are even expecting very soon. There are a lot of clinical trials going on to target things. There are new things that are coming on is release drugs. There are a lot of studies going on now that where we can give one eye drop, one injection that will last for a year to 3 years, but they are not yet there. So there's so much going on that will actually benefit us in the future. I think that is all I want to add on to when we come to start taking decision. PRN is what we do, yeah. As much as possible, I will propose to my patients, like Dr. Remy said, the 3 loading dose. Those who can afford, we go for it. Especially if the patient is coming the first time, you really want to just give it then, and the results are excellent. When you just give those loading doses, they are excellent. But you look at the economic status of that very middle list. Let me give this. Some patients, you never find them again. You give one, they disappear. They come back when you lower it, doesn't. The other thing Dr. Kasongole mentioned, I think the issue of when they switch to the other drug, visual acuity didn't improve. You see, the patient is not interested in how thick the retina is. The patient is interested in vision. So you should know when to stop. Yeah. If you dry the whole macula and still see, and what I know very well is that for AMD, you don't need to make it very dry. For diabetes, yes, you can. But AMD, you mustn't dry up everything. People are even advocating that if you dry it very much, you can start causing other problems. So there are some group of people who said, no, leave a little bit of fluid there and just monitor. So there is this controversy of drying completely. So this is where this study comes in, whereby the visual acuity is not that bad, and they really targeting those who dried it completely, and they may not see that big difference. And if you look at it, that is where Aflibercept actually doesn't make big difference. Aflibercept makes big difference when the visual acuity is bad. But when the differences are there, then all of them are almost not different. I hope I've made myself clear. If I've switched something, please let me know. Yeah. David, you have younger brain.
Sorry?
Your brains are still younger than some of us. Ours have got kids. So if I made something, that means you are the young ones. So you can add. But otherwise, I love the study. And Mulenga, you did very well. I really like
That's true.
the whole setup. That's great. Well.
Yes, one point, sir, you just mentioned about the keeping a bit of fluid there. That's
Yes.
actually upcoming. That's very true, because they say there are some studies, some case reports where they have tried to dry it completely with very aggressive anti-VEGF therapy, and then finally they develop the geographical
Yes.
atrophy. RP is gone.
Yes.
So it gives a protective effect. That's what they say now. We don't know what they will tell tomorrow, but then right now studies are going about that. I don't have that article to quote now. We'll try to get it next time.
Yeah, actually,
So,
the CAT trial had showed that the patients who had used Avastin end up with having geographic atrophy.
Yes.
So now, if we
yes.
look at like what this study also mentioned, that if Aflibercept has a high affinity for VEGF A and B, so it will essentially worsen what Avastin would have done.
Good.
So some gray areas there.
Yeah.
Very, very true.
That's good. I think it's 6 p.m. In our local time. I think the webinar was scheduled for an hour. We would like to thank everyone that had participated, and a very well job done to Dr. Mlenga. Some of the changes were done in last minute, midnight, but the whole package came out very well. So keep up with the good job. From my side, it's goodbye. Thank you, Dr. Amit.
Bye, everyone. Thank you, sir. Thank you. Bye.
Good.
Bye. Yeah.
Yeah,
Later.
just a few
Sure.
announcements. Or has everyone left already?
Yeah.
Yeah,
No,
so
we're still here.
yes. So just a few adjustments. The next presentation we're having next week will be Wednesday. They present, this will be on thyroid eye disease. And then the next consecutive 3 presentation will be on viral keratitis. So we'll have the introductory part on a Sunday. And then the other week, we're going to have a journal presentation on a Sunday again. And the last Sunday, the moderator is going to conclude with a lecture on complicated cases. And thereafter, we are going to go back to our Wednesday meetings. In between, we are going to have one Wednesday with Dr. Muma as a moderator on juvenile glaucoma. So we'd like to encourage everyone to be attending. I think the doctor from Mauritius and Dr. Sineja, we invite you again for the other subsequent ones. We understand that even though you are in retina, you still see other patients. So we still need your
Oh yeah,
Thank
sure. I love those actually.
Pleasure. Pleasure
In
doing that.
private practice, you can't stick to one thing. Otherwise, your clinic will be empty.
Yes. Thank you very much, everyone, and the presenter. Job well done.
Thanks.
Thank you. Bye-bye.
Bye.
Thank you.
All right.